Hey guys, welcome back to season 2, episode 5. I'm your co host Mo. In today's episode, we had the pleasure of interviewing pediatric speech pathologist Joanne. And this episode, she's going to be talking about the most important part of your kid's development, speech. In this episode, you'll learn all the myths and facts behind speech, speech delays, and all the good stuff. Hope you guys enjoy.
So, very excited. Today we have a guest who serves a population and performs a profession that is one of, if not the most common specialty that as a pediatrician I call upon. She, like me, is pediatric specific, but this can affect older folks as well. It's the most common manifestation of the most common broader pathology we see these days in kids. So we're seeing more developmental disorders than we've ever seen. And I've said it before, when I was in med school and residency, we barely studied or thought about that stuff. And the first, 5 to 10 years of my career, we barely saw any kids with real developmental disorders. It was pneumonia, meningitis. Now I don't see pneumonia, meningitis that often, and I see 10 kids a day with developmental disorders. The most common developmental delay is speech delay. It's super common. There literally isn't a day where I'm seeing kids in the office that I'm not making a referral for a speech delay. The good news, it tends to be isolated and it's very solvable thanks to really special people like my guest. But it's so common, it affects so many kids that we thought it'd be great to go a little deep on this tonight. And so we have the best of the best, a real expert in the field. We're just meeting today for the first time, but Mo and the team gave me some background, and Joanne is not only really smart and knows her stuff better than anybody in her field, but the way she's able to articulate it and explain it is pretty incredible. And she has a real big following on social media, and that's because she's exceptional at explaining. I always say, it doesn't matter how smart you are if you can't transfer that information, and she's got the gift of both. So with that, I'd like to give Joanne the opportunity to maybe just talk a little bit about your background. Yeah. We have similar backgrounds, it turns out, in terms of geography at least. Your origin story and how you got to where you are. And then we could get into the professional aspects.
Yeah, thank you. That was a fabulous introduction. I almost feel like I have nothing left to add, but I know that I do. So my name is Joanne Cazeau. I'm a pediatric speech therapist, and I serve the early intervention population here in New Jersey. I'm really passionate about caregiver education and really getting the information out to parents and families of littles about developmental delays, about speech and language delays, about how they can support them and what resources are available. So my story with speech therapy is like a little bit heartbreaking. So I was born in DC, and then my family moved to Haiti. When we moved back to the US, my sister and I were assessed by a speech language pathologist, but unfortunately it was not in English. And so I was misdiagnosed with a speech and language delay. Thankfully, my mom, she was my strongest advocate, and she said, hey, this didn't really go the way that it was supposed to. You know, she doesn't speak English. I really feel like if you give her some time and if you give her the right resources, she'll be able to catch up. And really, that's how I was able to learn about speech language pathology. So I'm from New Jersey, kind of like born and raised, kind of. And I did a clinical internship in high school, actually, where I shadowed a pediatric speech language pathologist. And every Thursday I would get home and be like, I had the best day ever. Wow. And I would go to school Monday to Wednesday. And then on Thursday I would know, okay, yeah, I get to go to the hospital and I get to shadow the speech therapist. And so I did that. I also shadowed an occupational therapist. I love them now, but I just knew that it wasn't for me. And I also shadowed a physical therapist again. Love them now, knew it wasn't for me. And then in college I pursued speech therapy, and that's really how I ended up here. I am one of 3% of speech language pathologists. So when I got my master's degree, I knew that not only it was important for me to serve my community, but also to be that representation of Black speech language pathologists, and also to disseminate information to families that aren't used to seeing me. And that's how I started my practice. The practice really started with me making sure that kids of color received the appropriate speech and language services, and then it really just blossomed. So that's a little bit more about my story.
Yeah, that's an awesome story. And doing what I do, we're kind of like brother and sister in arms.
Yeah.
Because, it is a battle. I think people think that when you work with kids, it's like rainbows and, unicorns. And it is in many ways. Like me and Mo always talk about, like, we love what we do because we can act like kids. It's the only profession where you're expected and encouraged to act like kids, because the more you do, the more you can connect with your quote clients, right? If I come in a suit and tie and I'm like stiff and I use big fancy words, and all I'm going to do is intimidate my client, and they're not going to open up and let me in, let me examine them, let me connect with them. And so it works out because I'm not good at that stuff anyway, right? And so we have a lot of fun, and that's the part that is usually fun. But then the other side of it, and this segues into kind of what you're talking about, Joanne, is many, many times there's unique aspects to a story that really cloud the picture and makes it hard for the doctors, let alone like the school teacher or the mom. So yeah, you do have, I don't know, maybe a percentage of kids that raised in an only English speaking household, non-immigrant, whatever, like it's clear cut. The kid's not talking and he's 3. Like you do have those kids, but you have a lot more kids where there's context to the story that can have 3 different speech pathologists, 3 different teachers, 3 different pediatricians come up with 9 different diagnoses. So if it's a primarily Spanish speaking household and the kid is, only at home, hasn't been in daycare, and then you're assessing their language and even personality traits that are influenced by culture. Like there's cultures where the family and the kid are more introverted. And so they say, well, like I'll go into a room sometimes for like the 18-month well visit, and I'll ask the parents, is Jimmy talking? And simultaneously, the mom will say no and the dad will say yes. And I'm like, wait, what? And they look at each other. They of course argue, because my other job is I'm like
counselor.
A counselor, like a what's it called, a couples therapist as a pediatrician. They argue over whatever, and then I'm like, what are you guys talking about? And they say, well, Dr. Baker. Then the mom says, yeah, he says 30, 40 words. And I'm like, oh. Then dad's like, yeah, but he only says them when he wants to. I'm like, buddy, that's him being shy, not delayed necessarily. And then you start to go in. So there's, and you honed in on the cultural stuff, which I think is really important. Different households can speak English different ways, let alone if they're multilingual. Actually, I was always the youngest in my class growing up. Like I was the only one without a car, and like that kind of guy. And the reason for that is I was raised in a non-English household. And when my parents, immigrant family, when they put me in school, they put me in like pre-K, and the teachers sent me back. They're like, the kid doesn't listen. He doesn't like understand us. So then they started teaching me English. And then again, immigrant family didn't know any better. They just put me in first grade, like the next year. And so like I knew a little English, but now I was the youngest kid because my parents, whatever. So, the misdiagnosis, mislabeling. And then there's, okay, he or she's not talking. I keep saying he because it's so much more common in boys, but he or she's not talking. And does it also signify, and I'm sure you're going to say a lot about this, signify something deeper? Like, is it just speech delay, or are we talking about something on the spectrum or something? And you mentioned you flirted with OT or PT, and you respect them, but they're not your passion. And then you start to pull those services in. And the interesting thing about speech, almost any of the myriad of developmental delays or disorders, almost any of them include speech issues, whereas speech can often be alone, right? Like very, very few kids. Again, I'm minimizing, but not by that much. Very few kids are getting OT and not speech, even though a lot of kids get speech and not OT. Very few kids are getting PT and not speech, but not the inverse, right? Speech is really the tip of the iceberg. And so in terms of development in the pyramid, it's really at the top of the pyramid. And so I think I'm really fascinated by how you do what you do, and then you're so astute to cultural, socioeconomic, whatever backgrounds, because that is critical if you're going to do right by the kid. If you're neglectful of those things, you could have a misdiagnosis and the wrong treatment plan too.
Yeah. So I will say that culture plays, first of all, communication, I feel like, is at the helm of everything. If you can't communicate, you can't get your needs met, right? So that tends to be kind of the trigger for seeking services, is that we'll get a child that is super frustrated, right? They might have dropping behaviors, or they're starting to elope, or they might have aggressive behaviors, right? But when you look deeper and when you bring a speech language pathologist into the picture, The issue actually is that they don't have enough communication skills. And then what I love to say, and it's not always, but I like to say that behavior is communication. Not always, right? Sometimes behavior is behavior, but usually behavior is communication. Your child is either trying to tell you that they need something, they're trying to tell you that they don't feel really well, or they're trying to communicate something. So when we're coming into the home, or when I'm coming in and doing my assessments, I really have to decipher what exactly it is that is happening. A lot of times, parents will complain or will come in and say, he's not doing this, he's not listening, he's not doing X, Y, and Z. And then I have to kind of walk back the pieces and try to figure out the pieces of the puzzle. Sometimes it just so happens that the child actually has an ear infection, right? So a lot of times I'll come in and mom and dad will just be like, well, he's been holding his ear and, he's been crying essentially. And so I'll say, has he seen an ENT, right? So we can start there. And then I'll explain to them, sometimes children, especially in this population, they'll get really frequent ear infections. And then that'll manifest to pain, right? And it kind of feels like sometimes when you have fluid, right, that's also involved with the ear infection, it kind of feels like being underwater is what I tell my parents, right? You're underwater and all kinds of sounds are really muffled. And so if they're hearing something that's really muffled and they're not really getting precise like speech patterns, right, modeled to them, then it's really hard for them to speak. So that could be one thing, right? And then I can walk in and parents are saying, like he's really not listening in daycare and he's doing this and he's doing that. Again, I'm saying he, but it really can be just any children. And then when we walk back, we notice, well, they're really having trouble communicating, right? So I feel like the communication piece can lend itself to a lot of issues, whereas families might not be able to readily notice that or, know that it's a communication issue versus like a behavioral issue. So that'll be the first part. But I will say language and communication and culture also go together. So one of the statistics that I talk about very often on my page is 16 gestures by 16 months. And I'll have a lot of families, because it's a list of gestures, pointing, waving, clapping, hands up, hands down, etc. I'll get a lot of families that say, oh, I don't think so-and-so has 16 gestures. And what I have to walk back with them in that conversation is, yes, we do say 16 gestures by 16 months. These are the most common gestures, but gestures even are cultural, right? There might be a culture where they don't necessarily point because it might be rude. In Haiti, yes. My parents will always tell me, no, you're not supposed to point, you're not supposed to point. So like culturally, it might be something that's inappropriate and that the child might not have access to in their home always, right? And so they might not be pointing, even though pointing is really like a pre-linguistic skill. We would really love to see it because children communicate via gestures before words. That could be an example of something that doesn't happen in the house, right? And so it's important to look at, when I'm coming into the home, how does the language that the family speak and how does the culture that the family is immersed in, how that might impact communication. And then of course, if the family speaks another language, I want to know about that language. What sounds show up in that language that don't show up in English? For example, I see a lot of French-speaking clients. I also speak French. Lots of my French-speaking clients will come in, and mom and dad will say, they can't make their TH sounds. The teacher says that they can't make their TH sounds. They're making the T sound. And I'll tell them, hey, in French, do we have the TH sound? And they'll think about it, and they'll think about it, and they'll be like, no. And I'll say, well, if that's not a sound that we have in that language, then it doesn't always happen naturally that there's a sound transfer to English, right? So then let's bring in speech therapy. We work on it for a few months and then they're out the door. So I think it's really important to look at culture as impacting communication.
That's incredible. That's like super insightful. And I see that on my side of the equation all the time. And it's great to know that you have partners that, fortunately we have a lot of really good partners, but it's always good to listen because, the family goes from you to me, and you always want to be aligned. And it's a funny thing between clinicians, right? If I'm a patient, I would want to know two things that seem like opposites, but to me are not. I'd want to know, one, that the different clinicians involved in my family's care are very much aligned in terms of the direction, communication, sharing information, sharing perspectives, but at the same time have no problem disagreeing respectfully in order to get the best outcome. So you don't want them to be so buddy-buddy, and I see both sides of the equation. You don't want them to be so buddy-buddy that like, hey, and I've seen this a million times, hey, this guy sends me a lot of work, so I'm just going to like always agree with whatever he or she says. I see that all the time. Yeah. And I also see the ER doctor who like every time they see a kid, they like talk shit about the primary care doctor and they say, well, I can't believe this. And I always, when I used to be in the children's, I would tell these ER doctors, I'd say, buddy, if these pediatricians didn't once in a while send the kid over for a CAT scan or stuff, you wouldn't have a job.
Yeah.
Okay. You are supposed to be the safety net. So just say thanks and send the family on their way. Right.
Yeah.
You have the ones that are extremes. And I think that collegiality where you could pick up the phone, the best relationships I have with clinicians, if it's a speech therapist, if it's a psychiatrist, if it's an ENT, 1 out of 5 times they pick up the phone. They're like, Z, I know you sent this kid for A, B, C, D. I'm seeing E. And then I'm like, are you? Well, yeah. So let's do this. And then a month later, the kid's better off for that. That collaboration, that respectful kind of collegiality works best for the patient.
Yeah.
What I'd like to do, Joanne, if it's okay, because this is such a rich topic. Yeah. There's so many manifestations of this every day in the office. I want to do like quasi rapid fire on things because we're so fortunate to have an expert like you where, hey, this scenario, and then I want to do a couple of those. But before I get into some very specific kind of peppering of questions, can we just deconstruct a typical case? I know there's no such thing as a typical case, but let's go with, there's a 22-month-old female. She says 2 to 3 words. She's otherwise fine. She makes good eye contact. She's got good gross motor. She could feed herself. She runs, she climbs, she throws a ball, but she really isn't talking. So she finds her way to you. I refer her to you for just speech delay. Can you talk about your intake, your assessment, and then your process?
Yeah. So a 22-month-old coming in with just a handful of words, that is a child that would be considered to be language delayed. So at 24 months, I'm looking for children to have at least 50 words. And I know that there's a range, right? And the higher number in the range seems to like scare parents, but that's not the number that I want everybody to focus on. So look at the smallest number of the range, right? That's the least amount of words that your child should have. So at 24 months, we're looking to 50 to 300 words, but I really want your child to have at least 50 words. So if they're coming in at 22 months, right, and they only have a handful of words, I don't think that we're going to get to 50 in time in 2 months. I definitely want families to be able to come in. And what an assessment looks like, I will say, I'll tell you what an assessment can look like, and then I'll also talk about what an assessment looks like in my practice.
Sure.
So usually an assessment will be, or like the process will be that the child will be evaluated or will be referred to speech. Then they'll come into the clinic. They'll have a formal assessment done. If that's something that they can tolerate, those can get pretty long. It will include some assessment materials, and then the clinician will decide whether or not that child is appropriate for speech. For the 22-month-old who only has a handful of words, they would be considered language delayed. And then the speech therapy would happen in the clinic, typically, right, at a rate of once a week or twice a week or 3 times a week or whatever the clinician finds appropriate. In clinics, it gets a little bit tricky because parents aren't always included in the therapy. But ideally, even if the parent is not there, that clinician would do the therapy with the child and then also give the parents carryover or home exercise programs. That's really where the magic lives because the therapy is only happening, again, 30, maybe 60 minutes a week, and that child spends the rest of their week with a caregiver, a family member, etc. So whatever strategies the clinician gives to the families, ideally they would use the skills or the strategies from that home exercise program and use it at home. And then in a perfect world, we see lots of progress. In my therapy and in my practice, it's very different. I go to the family's home. That is because I feel like offices can feel very sterile and very cold. So there's this thing called white coat syndrome. I get it all the time. And I'm a grown-up, so you can imagine a child, right? It can be very overwhelming. That's one thing that I love about your practice is that I can walk in and I feel like I'm at like the salon because it feels very welcoming, right? But sometimes offices and clinics, they can feel very sterile, and then we just don't get the true picture of the child. Yeah. And then you can hear like families a lot will say, I'm not really sure, like, this is not what they do at home, et cetera, et cetera. I go into your house because I want to see your child in their natural environment. And the assessment is going to be play-based because children learn the best when they're playing. So it's going to be super informal. We're down on the floor, we're playing, and that's how I'm collecting my data. And then based on that data, then I'll decide. We're going to start speech therapy. This is our frequency. And then the goals are something that we collaborate on. I have my clinical goals, and then I have the family goals. We come together. If you tell me, I want Timmy to tell me when he needs to go to the bathroom. That is a perfectly fine goal. That goes in my plan of care. And then the therapy looks like I come to your house every week, and then we do play-based therapy because, again, that's how they learn best. And then the progress happens that way. And then when the family is involved in the care, then they can take those strategies and use it throughout their day. So sometimes I'll do the therapy during the potty time,
Right.
or during diaper changes, or during meal times. That way it's natural. It's something that already happens during your day. Now you have the language to be able to model. And when I leave and I close that door behind me, you can do the same thing tomorrow. So that's what it would typically look like in either setting.
Okay, that's
Yeah.
awesome. That you painted a really clear picture.
Yeah.
So one follow-up, and then we'll get into kind of some quick Q&A.
Yeah.
I always tell families when they do any kind of therapy,
Mm-hmm.
speech, mental, PT, anything, even for them, for the adults, I always tell them, if you're coming to me or someone like Joanne for the answers and for the treatment, you're going to fail. You're coming for us for the guidance.
Mm-hmm.
And you have to go, like, I can tell you what not to eat and not to drink. You have to go do it. Can you go a little deeper when you give exercise? I think the word you used was exercises. Yeah. When you give these speech language exercises, can you give like some popular, again, every kid's different, but some of the more common ones as examples?
Yeah. So I'll give you maybe like my top 5.
Yeah.
So number 1 is get face to face. I don't know how tall you are. I'm 5'8". And what I tell parents all the time is I'm 5'8", your child is like maybe 2 feet tall. They're staring at my kneecaps when I'm talking, right? So if I'm standing up, they see my kneecaps, they can't really see my face. And one thing that's really important about imitating language, because again, children learn through copying and they also learn through play. If they're only seeing the bottom of my chin or if they're only seeing my knees, they can't really see how I'm making a specific sound or like saying a word. So I say get face to face. That's number 1. Number 2 is don't anticipate needs. So lots of families get into having routines and schedules, and that's all great, right? I like to have routines in the home, but what happens a lot is you already know that it's breakfast time, you're gonna have the waffles out and everything's kind of set up. That child hasn't had an opportunity to communicate because everything is just kind of like flowing, right? It's kind of like a train schedule, all right? Coming up next is the waffles, right? But maybe if we stopped and we said, all right, it's breakfast. Do you want waffles or do you want yogurt, right? Then we just created...
don't anticipate.
Exactly.
Right, Mo? We say that all day.
100 times a day.
Exactly. So then you've just created an opportunity for learning for that child. Another strategy I will say is whenever your child says one word, then add another word to it. Because I see a lot of kiddos that will come in that have lots and lots of single words, but they're not stringing words together, right? And then so it's really hard for them to be able to get a message across if they have that one word, but we don't really know like what else is supposed to go on with that, right? Like, do you want the waffle? Do you not want the waffle? Is it yucky? So adding a word, right? If your child says waffle and you see the waffle, you can say, yay, waffle, or like yummy waffle, or eat waffle. And that way you're building on to their vocabulary. Another thing is acknowledge all communication attempts. So one thing that I notice a lot of my practice is that some kids will use gestures. The gesture is really intentional, right? I don't want you to ignore that. If they're pointing to something, go, oh yeah, that's the light. Oh yeah, that's the couch. So if they're communicating something, even if it's like non-speaking or they're nonverbal, take that opportunity to acknowledge, right? Oh, you want the cookies? Come on, let's get cookies. And then that way you're mapping language onto their brain. And then another one I would say is pair actions with gestures. So that's really how children learn the meaning of words, and then they learn how to associate meaning to a word, right? So when you're clapping, you can say, yay, right? So that they understand, oh yeah, clapping is like a really fun, exciting thing. Or when you go, uh-oh, you can put both hands, right, to the side of your face. That's the way that children really start to learn language, I will say. So those would be like my top 5.
That's amazing.
Yeah.
Those are great tips.
Ooh,
I love it. It's so practical.
So practical, I was going to say.
Yeah.
And I mean, I'm going to like honk the team's horn. We say all of those all the time.
Yeah.
Right? For
That's
all our
good.
kids. Yeah. At different like visits. We give homework at each well visit.
Yeah.
And so on. And obviously development's a big part of it and speech is at the top of it. So like, can I give you a couple of quick ones?
Go ahead. I'll try to be fast. I know
I don't,
sometimes can
when I
get
say quick,
long-winded.
I don't mean for you to be fast.
Okay.
I mean, I have like all these like one-offs.
Yeah. Okay.
That's all.
I'm ready.
Dr. Baker, I have a kid. My son is 5, speaks great, hit all his milestones. The past 3 months, he suddenly started stuttering.
Mm-hmm.
He just stutters. How much does he stutter? Quite a bit. It happens like, several times a day. Is it a particular word? Yeah, it's more with this word, but kind of whatever. It just happens. Like, I feel like his mind's racing, blah, 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 blah. This happens all the time.
Yeah.
Can you talk a little bit about pathologic, not pathologic, signs to
Yeah.
worry, signs not to worry, and how to fix it?
Yeah. So I will say stuttering is like not my area of expertise, but I still know something because I have a master's degree and it costs a lot of money. So
Yeah.
here we go. So with stuttering, there's this thing called developmental stuttering, right? Usually kids under 3 will have developmental stuttering, and it happens when they're just learning so many new words, and now they have all these new words to put these new messages together. But sometimes they're just having trouble finding the words, right? And so they might get stuck on a word because they're trying to think of the next word to come. So that's called developmental stuttering. That will usually fade away, right? Once that vocabulary grows, and then once their syntax, which is the way that they put words together, grows. And then we have kind of like in the case that you're talking about, where a child that goes on not stuttering all of a sudden stutters. So I want to look at a trigger, right? What changed? So when I see a case like that, I ask the family, in the past 3 to 6 months, what has changed? A lot of times what I noticed is that there was a move, right? There was a new sibling or a new school or a change in kind of like the pattern of how things happen, or a new nanny, et cetera, et cetera. We'll still do the therapy to support the stutter, right? And then sometimes it'll go away because that major event has now passed. There's some kind of familiarity with the new routine, and then it will pass. And then there'll be a kiddo where it doesn't pass, right? That is more likely to be a true stutter. When I see that in my practice, I refer out to a stuttering specialist. So even within the field of speech and language pathology, just like in medicine, right? You can have a pediatrician or you can have a dentist, et cetera, et cetera. It's really the same with speech and language, where you have people who specialize in early language, you have people who specialize in stuttering and feeding, et cetera. At that point, I would refer out to a specialist. And with stuttering, I really want to harp on the fact that stuttering is just another pattern of speech, right? Some people don't stutter and some people do. It really is a spectrum. So it's just a normal pattern of speech for someone else. The goal is not to correct the stutter, and the goal is not to make it go away. The goal is really just to make that child feel comfortable with the pattern that they have. And then if they don't feel comfortable, giving them strategies. Yeah.
Great. Awesome. Tongue ties.
Yeah.
So I deal with tongue ties every day.
Yeah.
I find I think I'm pretty middle of the road given how much strong, vehement opinions there are out there. I'm the type of guy that every single day I see a kid that has a legit tongue tie and it needs to be addressed. And I know if we don't address it, it's going to cause feeding issues early, speech later, because it's legit. I also see every day a kid who was told, like a mom who's told that her kid has a tongue tie and the kid really doesn't have a tongue tie. Just she slipped off the nipple for 5 seconds and everybody overreacted. So I'm not one of those guys who thinks that they don't exist. I'm not one of those guys that think they exist everywhere. I think they do exist a certain proportion. They grade them mild, moderate, severe.
Yeah.
Can you talk a little bit about what you see out there and how it can affect speech and the right time to address it, and maybe severity informs that?
Yeah. So I will say with a tongue tie, there are tongue ties, right? Or with any kind of tie. So they're called like oral tethered tissues or like tethered oral tissues, right? You could have a lip tie, you could have a tongue tie or cheek tie. It really depends on how tight it is, right? So like the severity of it, and then what exactly it's impacting. Sometimes it's impacting latching, right? When children are being breastfed. Later on, when children are like starting to talk, starting to communicate, it can impact drooling, right? Sometimes we'll see a lot of babies that will just drool incessantly, and then we realize, oh, their tongue is literally anchored to the floor of their mouth, when we really want the tongue to be resting up on our palate, right? And then, so that's really hard, and then we just get kind of like drool just going down all over the place. When you take a look in their mouth, they have a really restricted tongue tie. I think that's probably like the better word to use, is like how restricted the tie is. And then you have some kiddos who are early communicators and they're starting to talk, and then we might get some speech sound issues or just like difficulty talking overall. So I think it depends on what exactly is being impacted, and then the severity of the tie, and then of course if it's causing any discomfort or pain. The best people who I tend to refer out to are airway-centric dentists. So again, like another specialty within dentistry. I refer out to ENT, and then just for like the heck of it, I might send them to pulmonology, just kind of like wrap it up and put a bow on it. And those people are better able to make a definitive diagnosis and then carry out with like a good plan of care. That's great. Then I will just add, with tongue tie, because that's the part that gets missed, you want to do pre and post-op exercises. Correct. That has to happen with either an orofacial myologist or with a speech language pathologist who has training in tethered oral tissues.
Absolutely.
Yeah.
That's great. multilingual households. So I get, and I know this is an area of focus for you.
Oh,
I get a
yes.
lot of families. Dr. Baker, we're both Brazilian. We speak Portuguese. I see them in my Edgewater office. Like I see all these families.
Everywhere.
We have a very internet, just by virtue of where we open, like
Yeah.
Edgewater, the Upper West Side, Brooklyn.
Even Paramus.
Yeah, we have which is why I love working here.
Yeah.
I mean, you learn so much from having a diverse clientele,
Yeah.
right? Like I didn't know that. They didn't teach me in residency like massage babies, and then my Indian families talk about massage. Then I do some research and improve circulation. Kid can't walk, so the circulation's not. So you learn that. You learn about the benefits of spicy food, like antioxidants and healthier diets, and so you actually are a better clinician as a result. The more diverse your clientele, the more weapons you kind of develop, and you could help folks. But you have a family; they're Brazilian, speak Portuguese. They're here for work, but they're born at the mom and dad are born and raised in Brazil.
Yeah.
Pure Portuguese at home. The grandma's staying with them now with the baby. Guess what? She speaks Portuguese. Yeah. And the kid's like 1.5, talks a bit, but the little bit he talks is just Portuguese. They're worried. They want to put him in school eventually. And they say, Dr. Baker, should we just focus on English? Should we do flashcards in both languages?
Wait.
Give us some advice.
No to the flashcards in general. Flashcards are boring to most kids. They're super repetitive. Kids just end up memorizing things via rote memory. Then you think they're talking, but really they've just memorized what's on the picture. I don't love flashcards. Kids really learn through like interaction and real life experience. So I will just put that out there. So one misconception is that a child that's exposed to multiple languages, or if they're not exposed to the main language, that they'll have some kind of a delay. And then I get parents who just run around frantic, not really knowing what to do. And what I say is speak whatever language that you would like to in your home as much as you would like, as long as they naturally flow. And it doesn't really even matter how fluent you are in it, because I'll get some families who say, well, I was born here and I speak a little bit of Portuguese, is it worth it to speak to them? Yeah, it is. You're still teaching them a different language. And who was ever really fluent, right? In like a language, even if you're a bilingual, you might not be a balanced bilingual. I know more English than I do Creole. It's all kinds of like works out in the wash. What I will say is if families are worried that there is going to be a delay, right? I don't want you to just speak one language in the home. So there's different methods that you can use to encourage bilingualism or multilingualism. So one of them is called one parent, one caregiver. That means mom maybe might speak Spanish in the house and then dad will speak English, right? And then there's another method where it's like place and time. So at breakfast time, we will speak Spanish. And then throughout the rest of the day, we'll speak English. The other method is everybody does what they want, right? Everybody's bilingual or multilingual, and the languages just kind of come out throughout the day naturally. What I will say is exposing your child to multiple languages will not delay them.
Right. That's what we used to think.
Yeah, exactly.
That's how I was trained.
And that research has been just persisting and persisting and persisting. It's kind of like hard to reel back, right?
Yeah.
But it doesn't cause a delay. It will not confuse your child. That's another thing that I will hear too, is like they'll just be so confused or they'll be so overwhelmed. But children are really in the best position to learn multiple languages, even more so than adults.
Correct.
Their brains are super plastic. Up until 12, they can learn as many languages as possible and still sound native. That's the part that really gets me, right? Because you and I will probably need Rosetta Stone, a couple of videos and DVDs, and really to like go there to really
I'm losing my
immerse
English
ourselves.
at this point.
Exactly. See, we're like failing over here. We're struggling. But then kids are able to pick up languages like we're, because that's how their brain is designed. So now is really the time to introduce those multiple languages. It won't overwhelm them and it won't confuse them. And the research shows that children are able to separate their different languages. They know when you're speaking Spanish, they know when you're speaking English, and then they know how to use them. And then they understand each one separately. Right. So that's what the research says. Yeah.
Can I ask you, because I've spent most of my career at the 4-month, 6-month marks, telling patients, start doing 30 minutes of flashcards, single word, single syllable with a picture. Tell me when.
Dr. Saeed Baker.
tell me when should we start talking about language in a deliberate way? Obviously, they're talking like at 2 months. I tell them to reciprocate social cues, converse with the baby. But I mean, where take something like a book, whatever, and what is the best way to do it? Like, so the kid's 4 months, 6 months, 9 months. Tell me what's a better way to advise my patients?
Yeah. So during their routines, right? So things that are happening already every day,
Okay.
those all have some of the best opportunities to target language. And targeting
So
language.
like during a diaper change, for instance.
Exactly.
Okay.
So targeting language doesn't have to look like stopping and deciding, all right, we're going to work on this right
Okay.
now, and then sitting down and doing it. It could happen as naturally as whatever routine is happening. So during the diaper change, right? So like our kiddos in the first year have either 8 to 12 diaper changes a day, right?
Yeah.
So think about how many hundreds of thousands of
Yeah.
learning opportunities those are. They're already down on their back, right? And you're hovering over them. We talked about face to face. That is like the best face-to-face time, right? So you have about like 1 to 2 minutes, depending on a diaper change. If it's an explosion, I'm sorry. But you have about like 1 to 3 minutes to really get language in there. So what can you do? You can sing a song, right? Changing diapers, so much fun, or whatever it is. Then kids that young are working on something called object permanence. So object permanence is just because it's not here doesn't mean that it doesn't exist, right? So what can you do? You can play peekaboo, right? You cover your eyes, peeka, boo. And they're looking, they're working on looking at you and also knowing, oh, just because dad's eyes disappeared doesn't mean that it's not there. And later on, that translates to just because the red car is not in the room, that doesn't mean that we can't talk about it, right? So like that translates to a later developing skill. Right. You can talk about what they're wearing. You can play I spy your toes. Then now you're working on body parts, right? So there's many opportunities within that one diaper change that is going to happen anyway. Like your kid is going to poop and they're going to pee, right? So then you take that opportunity to be able to target language.
Okay, great.
Yeah.
That's useful. Selective mutism.
Yeah.
So we have families where they'll say, Dr. Baker, Samantha is 4. When she's home, she doesn't shut up. She talks to us very clearly. She's very social. She's very curious. She's actually a very articulate communicator. She never talks when she's outside the house. Mm-hmm. And when I say never, I mean zip.
Yeah.
And anybody outside the house tells us they think she's autistic. Mm-hmm. They think like, but here, and then I'm looking at her, I'm taking a history, I'm looking at her, I disarm her, she says some words, she laughs, I hear her talk to the parents. I know there's nothing wrong. Mm-hmm. I know, but can you talk about selective mutism in general, specific signs, symptoms, when you should worry, when you shouldn't?
Yeah. So selective mutism is it's a psychiatric disorder. It's a psych disorder before it's a communication disorder. It really is a combination of both.
Right.
But it falls under the umbrella of general anxiety disorder, right? And so selective mutism happens when children in just specific situations will be completely mute. So they won't say anything, like literally like not even a peep. They might go into school and just be completely quiet, but when they go home, they're like super, like exciting and they're super talkative. What happens with selective mutism sometimes is, and I'll kind of like tell you my course of treatment, is that sometimes there's like a trigger, kind of like the stuttering where there's like a trauma trigger, and then that child will just stop talking. So what I like to do again is when I'm doing my interview or like my intake, I'll say, what has changed? When did you notice that this happened? So I actually have had 3 selective mutism clients in the past year. And one of them, I asked mom, I said, when did you notice this? She said, I really noticed it when he turned 4. I said, what happened when you turned 4? Let's kind of like go back and talk about it. Oh, well, I said, did anything traumatic happen, et cetera, et cetera. And she said, oh, well, I was fighting breast cancer. I said, oh, wow, that's really hard. I'm really, really sorry. Are you in remission, et cetera, et cetera. And I said, having a parent who is dealing with cancer is really, really hard. And, it's really hard for children to see that their experience is not like everyone else's. And then she said, when we would go to the park, the only thing that I could do was sit down. And he was the only one who was playing without his mom, right? And then in the midst of that, there's also a divorce. So when you look at all those pieces, and she really sat back, she said, wow, he really hasn't had a traditional childhood, right? So my first course of action was, I'm not even going to charge you for this assessment. I'm going to refer you to a pediatric psychologist. And I said, I want you to go see psych for 6 months and then come back. Before 3 months, she called me and she said, he won't stop talking in school, mm-hmm. right? So sometimes there is that particular trigger that we need to go back to and then identify that. My first course of action is refer to psych, give it a little bit of time. If it's not resolving right away, then speech and psych can collab together. But sometimes just sending them to psych will really start to show a difference.
Okay.
Yeah.
That's excellent advice. I see that all the time.
Yeah.
I agree 100%. I'm going to ask like one broad question, and then if we have a few questions that we've collected from
mm-hmm.
like viewers and followers. I love language. I think my minor, I forget, my wife would know this. I met my wife, we have that DC connection.
Yeah, we sure
So
do.
I met my wife at George. So I told you, I'm one of three.
Okay.
All three of us went to school in DC. I'm a Jersey guy, but we ended up in DC. My wife is from Florida.
Oh, okay.
She's one of 7.
Jeez. Wow.
Her dad was an OB, so
Yeah. Babies.
yeah.
Babies.
her all 7 of them
Mm-hmm.
went to DC school.
Oh, wow.
So the 10 of us, my family and her, all 10, and several went for undergrad and grad school.
Okay. Wow.
Yeah. But I only went for undergrad. Then DC kicked me out of the city. My wife actually, she has a couple of graduate degrees. One of them is from GW, like you.
Okay. Oh, nice.
One of the things that I wanted to ask when I was in school, I think it was my minor, was language. I love language because I took at least a bunch of courses in it. I think it was my minor was linguistics, and I was asked once, I don't know if it was like on one of these things or whatever, like, oh, if you could give your kid kids, I have 2 boys. If you could give your kids whatever, if you could imbue like certain features, like what are some like everybody you want your kid to be hardworking, you want your kid to be a good person and respectful and high integrity, but what are some like what trait, what unique ability? And I said communication, to be a very effective communicator. I find the ability to communicate to be the cause of much good that otherwise wouldn't have happened in the world. And more importantly, if you're a good communicator, I think it averts much of the bad that happens in the world. And I think most of the issues that exist, and when I say the world, I mean between a husband and wife, between a friend, between anybody, and all the way to between countries, is miscommunication, misunderstanding, miscommunication. And I don't think I'm overstating it by saying the ability to articulate clearly what's in your head is a very, very rare ability. And I know this is, kind of over the moon, but it is what you do. And, I think you're probably the best person to ask this. I just like a high level view. You've devoted your career to language.
Yeah.
I'm passionate about it. I think it's one of those things that, like, especially in today's day and age, when you read, you develop, you get verbiage, you develop, a vocabulary, you learn how to syntax, all these things.
Yeah.
There's less reading taking place today than ever before. And there's more just kind of passive, like it's visual, which, and I'm not judging one way or the other, I'm just stating. And so I find that communication skills maybe aren't as emphasized as they used to be. Can you talk a little bit about just kind of your general perspective and general tips? So we've talked a lot about if a kid comes in and we're worried about a delay or an issue, but just talk about, hey, there is no red flags, but here's my perspective on how to make sure you optimize linguistic development of your family.
Yeah. So one tip that families are told all the time, which I always disagree with, and I'll tell you why, is to talk to your child all day. That is not a tip that I agree with. So if you want to support your child's language development, I don't want you to talk to them all day. Why? It's overwhelming for you. It's really exhausting, and your child will get tired of you. Please leave me alone. So I'll tell you a few things. So read to your child. So children who are read to at least once a day, every day, they have 290,000 more words, right?
How long? Like 30 minutes? What are we talking?
Oh, just like reading every day. And I will tell you something, most kids can't sit for 30 minutes anyways. So as long as you can, as much as you can, as long as it happens every day, if you can. I know that a lot of families just don't have that allotment of time, but that's what the research says, right? So if you do read to your child once a day, at least every day, then their vocabulary will skyrocket, right? And reading doesn't necessarily have to look like reading every word on the page. I don't advise families to do that. Look at the picture and use the picture to tell the story, right? If there's a little boy playing, you can say, look, he's playing. Meanwhile, the text can say, little Johnny went down the street and he went to go play. But I don't necessarily need you to read that because plots can be overwhelming for children. They can kind of go over their head as young as they are, right? So look at the picture and let the picture tell you a story. And then you can also use your child, right? Look, what do you see? And maybe you might say, baby. You go, yeah, the baby's crying, right? So using books. The other thing I will say is using real life experiences and playing. So play, again, is how children learn, right? Children don't really learn from flashcards or from screens. Well, we can have that conversation if you want to. But children learn from like real life experiences. So going outside, I feel like not enough children go outside. And I talk about it a lot. And the research is actually pretty scary. Do you want to know how many hours a day a child should be going outside?
Should be going outside?
Yeah.
4?
3 to 8. Yeah. 3 to 8 hours. And most kids aren't getting that, right? Parents are super busy, which I understand, right? Some kids are in school, they're only really getting an hour a day, but they really need at least 3 hours a day, right? So as much as you can, go to the park. Go to like an arboreum. I know that they have those around, right? You can just go for a walk, right? And while you're going for a walk, talk about what you see. Whoa, there's a car. Whoa, do you hear that airplane? It's going zoom, 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 or whatever else, right? So doing lots of outdoor play, it works on their cognitive skills and also helps them with risk assessment, right? They have to manage kind of like the pavement and kind of like the territory as they're walking around. If they fall down, you can use that as an opportunity to talk about like, uh-oh, whoa, did that hurt, right? You can talk about their feelings and et cetera, et cetera. So I will say reading, playing outside, and then real life experiences. Take them outside, right? Take them to the mall. Even if you just walk around, right? You can talk about what you see, talk about what you hear. So really using those real life experiences to teach.
So let's get into some of the questions. The first question we had, someone asked, can you emphasize how toxic screen time is to a child at a young age?
Oh, okay.
Talk about a leading question.
Yeah. All right.
To start off strong.
The word like toxic just like kind of like got me. So I'll tell you my perspective on screen time. And then I'll tell you what like the American Pediatric Association says. So before 18 months, the APA says not to introduce screen time. And that's because children, again, learn through, interactive and real life experiences. And screen time can be very passive, right? Like playing screen games and then, watching things on the screen can be very passive, and children need to learn through active activities. Mm-hmm. That said, screen time happens, right? Mm-hmm. Like it happens in families, right? And so I think I want to take that focus away from screen time is bad, don't do it, to if your family does use screen time, here's a way to make the most out of it, right? Okay. So my first tip is to co-watch or co-view. So that means that you and baby or you and toddler are sitting together. You're watching the show together. That gives you an opportunity to comment about what you're seeing, right? Also gives you an opportunity to pause it. So I love the pause button, right? Go ahead, pick up that remote and pause it, right? Because even for the shows that are supposed to be a little bit slower paced, they still move pretty quickly, right? Yeah. Sometimes they're still too fast. So you pick up the remote and you pause it and you can say, did you hear her say that? Or like, what did she see? She saw a tiger or whatever. And you can say, oh, you have a tiger. Then you pick up the tiger toy. Oh, the tiger says roar. So it brings the experience from the screen into what would happen in their real life, because they just see it on the screen. There's no real connection to what's happening in their real life. You pause it, you repeat what they said, or you ask them a question about what they see, and then that way you're making it real life. The other thing that I will say is, so we talked about pausing. Oh, look at the quality of the screen time. So some of these shows are like really fast. There's like bright flashing colors and there's music like every other second. Try to find something that's a little bit slower pace, a little bit calmer, and that has a meaningful, almost real life plot that would imitate something that they would see in the real world. If your child is playing some kind of game, I know there's like a lot of educational games. Test out the game and see kind of like what's happening in the game, and if it's really super appropriate for them. And then just think about your child. You know your child best. So the show that they're watching, do you think it's appropriate for them? Do you think it's overwhelming for them, right? So when I think about the 3 C's, it's the content, and then it's the child, and then it's co-watching. So those would be my 3 C's. Screen time, again, I don't recommend it because I think that there are other ways to support a child's development. But if it's happening, just think about those 3 C's.
That's really practical.
Yeah.
By the way, my kids used to hate, they're older now, they're like teenagers, but when they were young, they used to hate watching movies. They enjoyed it in some ways because unlike their mother, like, I don't care if it's rated R.
Yeah.
So, like, they can watch anything. Like, I remember once she came home. I mean, I could tell you so many stories. She would leave them with me, go, like, to dinner with her, like, bougie friends, come back, and she'd see us, like, watching, like, He Got Game. You know how Dean loves basketball.
Oh, my gosh.
So, like, every other scene in that is, like, inappropriate. But but every other scene in between is awesome. And a life lesson, right? Like, kid made it from nothing, like the father-son dynamic.
What were you watching with Izzy the other night? You were talking about it yesterday.
Which one?
You said you were watching a movie with Izzy the other night.
Ninja Turtles. She loves the Ninja Turtles. But like I would watch like that Lincoln movie with what's his name, Daniel
Chad.
Day-Lewis.
Okay.
So that's like I would pause every 3 seconds because it's like the Civil War and like lessons and like
Yeah.
all this the assassination. What was that Kevin Costner JFK where he gets assassinated, whatever. And a movie that's like 2 hours, it would take every night for a week to get through.
Yeah.
Because I would pause every scene and be like, all right, so this. And I think like, they liked the fact that they got to watch adult movies, but they didn't like the fact that we were pausing a lot. But I'll tell you something, I think that pausing mechanism is huge.
Yeah.
You're right. It's like, because when you talk about going outside into the real world, you could also pull in the real world from these kind of like moments. It's really useful, practical tips, right? Like, you're right.
Yeah.
Next question we had, someone asked, can you touch upon the debate that, well, it's not a debate, it's shown in facts, that boys are more likely to get speech delays rather than girls?
Yeah. Okay. I was like waiting for that question to show up. So it's one of those scenarios where, you know how when a big piece of research comes out and you might see in the New York Times, it says, Dr. Zaya Baker did da-da-da-da-da, and that's the title. But until you click, right? Like oranges are better than grapes, right? Until you click, it's like, oh, oranges are better than grapes when you put them in, fruit salad or something like that. Exactly. You kind of have to read a little bit past the headline because the headline is always going to grab you. So the research shows that within the range of normal development, when first words show up, so first words will typically show up on average between 8 months to 15 months. So within the range of normal, 8 to 15 months, girls will talk a little bit earlier in the range than boys will. So they're still within the range of normal, but whereas maybe a girl might say her first word around 11 months, a boy might say his words closer to 13 months. So it's still within that range of normal. It's just that boys are delayed just a little bit by like a month or two, right? But it's not that they're so delayed that we're expecting them to be speech and language delayed and it's fine, right? It's not such that if your child is 24 months and they haven't said a word yet, that it's like, oh yeah, but boys talk later. No, it's within the normal range. Correct. Boys typically will start saying their first word towards the end of that normal range versus girls.
Yeah, and I see that scapegoatism happen.
Yeah.
Right? Like where, yeah, you're right. I see that. Or the other thing I see a lot, that's exactly right. Like,
yeah,
exactly. I mean, you say it so well. The other thing I see that's related is I'll get a kid and the parents, let's say they moved in from like Manhattan and I'm seeing them in Jersey for the first time. Mm-hmm. And I'm seeing them now because they have or they have like a baby and they have a 6-year-old.
Yeah.
Now the baby's like 17 months old, 18 months old, not talking. And when I'm asking them, they're like, yeah, he doesn't really talk, blah, blah, but they're pretty casual about it. I'm like, he doesn't talk. Mm-hmm. Like he doesn't say anything. No, he says like 2 words, Dr. Baker. I'm like, well, we need to like look into that. Like, you should be saying more. Then I do like the assessment. Like, is he making eye contact? And I reassure myself there's nothing else. But he's definitely language delayed, like for sure. And I'm like, all right, is he in daycare? No, he's not in daycare. Okay, he's just home. Okay, I think he needs a kick in the butt. Like, I'm not too worried, but I do think we should get some speech therapy going. Blah blah blah. Well, no, Dr. Baker, his brother who's 6 was the same. Mm-hmm. I hear that all the time.
Yeah.
And I'm like, yeah, a couple things. Like, 1, recency bias. Like, you might remember it a certain way. Yeah. 2, that's great. It might have worked itself out, but we can't superimpose these generalizations on the individual child. And I think that's really important.
Yeah. And one thing I'll add to that, if I don't mean to interrupt, but one thing that I'll add to that too is even when children appear to catch up without any professional support, they are at a higher tendency for having other troubles, right, later on in academics, social emotional development, reading and writing, right? So even when language delayed children do catch up, then there are some other things that can happen down the line where it wasn't addressed professionally before, and then it translates to academics or social emotional development. So that's one thing that I wanted to add to, which is why we don't do wait and see, because we don't really know who's going to catch up, who's not going to catch up. And then even if they do catch up on their own, there might be some other manifestations of that delay later on.
Exactly. Mm-hmm. Hey, I'm a big daycare guy. Parents always come to me and
that
they're
was
like, Dr. Baker.
One of our questions.
Yeah.
Can I ask it?
Yeah, ask it.
Yeah,
sure.
So the question is, can you Can you talk about the importance of putting a kid in daycare / not seeing the same set of people every single day?
Yeah. So I hear a lot from some of my families that will say, oh, it's because, he's not talking, but I really feel like it's because I didn't put him in daycare. Or if it's because, I'm a stay-at-home mom and I'm also working and then we don't get to go outside much. And what I tell families is that up until the age of about 4 or 5, children get all of their social emotional needs met by a caregiver. So that caregiver can, yes, be a daycare employee, but that caregiver can also be you, or it can be grandma, or it can be whoever else is in the house. So if you never actually really left the house at all, right, until like their 5th birthday, they're still getting that the social emotional needs met by you or by whoever else is in the house. Now, where the responsibility falls a little bit, and I hate that I use the word responsibility, but kind of like where that change or like shift needs to happen is that, okay, while they're in the house with me, what can I do to be able to support their development while they're here? So daycare, I think, daycare can be really expensive, right? And so if families are able to put their children in daycare, that's great. If families don't have the means to put their children in daycare, or if they're like afraid to put their kids in daycare, et cetera, I get some families that say, I really don't want to put him in daycare until he can tell me, what happened at school, or if he got hurt at school, et cetera, et cetera. If your child doesn't make it to daycare, right, and then they just kind of like start 1st grade, that's okay. As long as at home you're doing these little things to be able to enrich their development, but they're not necessarily missing out because they're not socializing.
Yeah.
And then the great thing is there are parks, right? There's mommy and me or caregiver and me classes. So there are other opportunities to interact with other people outside of like a daycare opportunity.
Yeah. I agree. I think, here's what I think. I think as long as the caregivers are conscientious of the need to not plop the kid in front of a TV for or whatever. I'll have the nanny just walk around the block 85 times until you get home from work. But or throw in a mommy and me class, throw in whatever, take him to the park and get that stimulation. And even beyond speech, just peer socialization. Because even if the kid's linguistically advanced, they could have severe social anxiety because now they're around a bunch of people and they're 6 for the first time. And they don't know how to deal with, people who aren't just wiping their butt, right? Like peers and so on. Yeah. So I agree with you. I think that's a good way to frame it up.
Yeah. So I definitely say for that situation, set up opportunities for them to communicate outside of a daycare opportunity, and then create opportunities for them to get that enrichment at home. Yeah.
Awesome. And then the last question before we wrap up the medical side of things, someone said, what's one tip you could give to young parents or any parent that you would give to them to help develop the kid's speech?
Oh, I feel like one is hard.
You could give a couple.
Okay.
It's usually never one.
Yeah. Okay. So I'm like, one is really, really hard. Oh, I think I can wrap it into one. Be intentional. I think so. Be intentional about the experiences that they have. Be intentional about the things that they're exposed to. And then just kind of think about how potentially that can shape their development in the long run. So be, intentional about, for example, shows. If you're going to do screen time, the language that you use, you will be very, very surprised how many kids whose first words were the F-bomb, right? So kids are listening all the time. Exactly. And they're just kind of dropping and everybody's like, oh, where'd they get that from? They've heard it from somewhere, right? So be intentional too about the language that you expose them to. And then be intentional about the experiences that you give them.
Yeah. I mean, I think Joanne's so bright. That last question is what that my answer to everything. You could ask me any question about pediatrics. My answer is always be the type of person you want your kids to be.
Yeah.
And that intentionality, the deliberation, all I do is screw up all day. I'll use foul language by accident. I will mistreat somebody. I could have done a better job of how whatever, right? My day is full of mistakes, right? Mm. I do think that my day is full of a lot more things I'm proud of than things I'm not. Mm-hmm. But what I always know is whatever mistakes I make are the mistakes my kids are going to make. Mm-hmm. And I try to minimize them. And, whether your kid's first word is the F-bomb, of course the kid learned it from me. The kid, it didn't just pop in. Hey, my kid, Dr. Baker, he only eats crap. I'm he's 6. He doesn't have a car and job. He can only eat what you're giving him.
Yeah.
That's the bottom line here. Now, listen, my kids eat Chick-fil-A more than they should. I'm not judging.
Yeah.
But I know that I'm the problem. Like,
Yeah.
so that intentionality, like, actually is everything.